Welcome to the Trachomatous Trichiasis Surgery Training DVD. This is an interactive DVD designed to be used by people learning to perform trichiasis surgery for the first time, or for those wanting to refresh their knowledge and skills. It can also be used by surgical teachers during a training program to illustrate their lessons. It is aimed primarily at people working in low to middle income settings in trachoma endemic countries. This DVD should be used in association with training materials produced by your National Eye Care Programme and the World Health Organization Trichiasis Surgery Manual. You will learn about the practices and procedures which are important in the provision of a safe, high-quality trichiasis surgical service. Trachoma is the commonest infectious cause of blindness worldwide. The disease is endemic in more than 50 countries, mostly in Africa and Asia. In 2004, it was estimated that there are about 2 million people blind from the disease and a further 8 million living with trichiasis. Trachoma is caused by recurrent infection of the conjunctival surface of the eye with the bacterium Chlamydia trachomatis. Chlamydia trachomatis is spread from person to person in several ways. Direct person-to-person contact, on objects such as towels or sheets, by flies traveling between eyes. Limited access to water and sanitation and crowded living conditions promote the transmission of infection. Repeated infections start in childhood and continue into adult life. The disease can be subdivided clinically into two major stages. 1. Active trachoma, which is mostly seen in children, and 2. Scarring trachoma, which is usually seen later on in life. To diagnose active trachoma, you need to avert the upper eyelid and examine the tarsal conjunctiva. This photograph is of a normal, healthy conjunctiva. You can see the deep blood vessels clearly, and the tissue is not inflamed. Active disease is characterized by a follicular conjunctivitis of the tarsal conjunctiva. In this photograph, taken of a child with active trachoma, you can see multiple follicles in the conjunctiva. These are white or cream-colored spots, which are at least 0.5 millimeter in diameter. In addition, you may see papillary inflammation of the conjunctiva. The conjunctiva usually looks quite red, and the deep tarsal blood vessels are not visible. The tissue is inflamed and thickened. Scarring trachoma. With repeated episodes of active trachoma, the conjunctival tissue is damaged and scarring develops. In this image you can see white bands and lines of scar tissue. Over a number of years, the scar tissue accumulates and contracts, rotating the eyelid inwards, as you can see here. This is called entropion. As a result of the scarring, eyelashes come into contact with the eye, scratching the surface of the cornea, which is both painful and sight-threatening. Eventually, the cornea is damaged, leading to opacification and blindness, which you can see in this eye. To control trachoma, the World Health Organization and its partners have developed an integrated program to fight the disease at different stages. This is called the SAFE strategy, which stands for surgery for trichiasis, antibiotics to control the infection, facial cleanliness to remove infected secretions, and environmental improvements such as improved access to water and sanitation to limit the transmission of infection. The focus of this DVD is the first component, the surgery for trichiasis. The eyelids are very important for the protection and healthy function of the eye. Before you start to learn about surgery for trichiasis, it is important to understand the key anatomical features of healthy eyelids. The eyelids are composed of several layers. Here you can see the eyelid opening up to give a cross-sectional or sagittal view of the inside of the lid. On the outside is skin. The lower end of the eyelid is called the lid margin. The skin meets the conjunctiva at the mucocutaneous junction on the lid margin. The eyelashes are at the lower end of the lid and emerge through the skin, pointing forward away from the eye. Underneath the skin is a layer of muscle called the orbicularis oculi. This muscle is important in closing the eye. The skin and the orbicularis oculi muscle together form a unit called the anterior lamella. Behind the orbicularis oculi muscle is the tarsal plate. This is a firm layer which gives the eyelid shape and some rigidity. Within the tarsal plate are the meibomium glands. You can see the ducts of the meibomium glands opening just in front of the mucocutaneous junction at the lid margin. The final layer is the tarsal conjunctiva, which lines the inner surface of the eyelid, providing a moist, smooth surface to rest against and protect the surface of the eye. Together, the tarsal plate and the tarsal conjunctiva form the posterior lamella of the eyelid. The eyelid is lifted by a group of muscles called the levator complex. These arise in the superior orbit and insert into the upper border of the tarsal plate and the anterior lamella of the eyelid. The blood supply to the eyelid is provided by several arteries. The main one is the marginal artery, which runs across the eyelid in the lower end of the anterior lamella about 2 mm up from the lid margin. Even in areas with a high prevalence of trachomatous trichiasis, patients often do not attend for surgery. There are many reasons for this, such as the associated costs, having inadequate time, fear of the surgery, or lack of people to accompany them to surgery. More people are likely to attend for surgery if you offer surgery in locations close to where patients live, and if you advertise widely about the campaign. You could advertise the surgical campaigns in markets with a loudspeaker, in local religious centres such as churches and mosques, in meetings of local leaders, in schools where children can be asked to pass the message to their parents, and by local radio. Before starting trachomatous trichiasis surgery, you must thoroughly assess, counsel and consent the patient. Ideally, this should be done in a quiet, private area. You should sit opposite the patient. Briefly explain to the patient that you will need to ask them a few questions and examine their eyes. Ask the patient, are you aware of having trichiasis? Do you epilate? Have you had previous surgery to the eyelids? Do you have any general health problems such as high blood pressure, shortness of breath, bleeding problems? Do you take any medication? And do you have any drug allergies? If appropriate, ask the patient if they could be pregnant. To examine the eyes, you should use a bright torch and a pair of magnifying loupes. You need to examine the eyes for the following features. Eyelashes. The normal eyelashes arise from just above the lid margin, in front of the meibomium gland openings. They should form a row, called the lash line, and all point forwards, away from the eye. Trichiasis is defined as having one or more eyelashes touching the surface of the eye. When you see eyelashes touching the eye, it can be for one of three reasons. Firstly, there may be inrolling of the eyelid. This is called entropion. Secondly, there may be metaplastic lashes. These are lashes that grow from abnormal places, usually behind the normal lash line. Finally, the lashes may be misdirected. This is when lashes grow from the normal lash line, but instead of growing out forward, they point backwards. All three of these types of trichiasis can occur simultaneously in the same lid. When you examine a patient for trichiasis, ask them to look directly ahead. This is called primary position. Then ask them to look up. Count the number of eyelashes that touch the eye. Look carefully for any lashes that are touching the cornea. Try to decide whether you think the lashes touching the eye are entropic, misdirected, or metaplastic. Entropion is the inrolling of the eyelid. To determine whether there is entropion, you need to examine the angle of the lid margin in primary position. The lid margin should be square in cross-section and run parallel with the floor. When there is entropion, the lid shortens and the lid margin rotates inwards and often becomes rounded. Tarsal conjunctival scarring. The tarsal conjunctiva should be examined to assess the degree of scarring and inflammation. To view the tarsal conjunctiva, you need to evert the upper eyelid. To evert the upper eyelid, ask the person to look down. Then gently hold the edge of the eyelid and flip it up. It's usually easier to do this over a swab stick or similar narrow object. Then examine the conjunctiva for the amount of scarring and inflammation. The scarring usually appears as white bands. In some patients there may be signs of inflammation with redness and thickening of the conjunctiva. Corneal scarring. Corneal scarring is the blinding stage of the disease. You should assess the cornea with the torch held from the side. This helps to show up fainter opacities more clearly. Lagophthalmos. Finally, you should assess eyelids for incomplete closure. This is called lagophthalmos and occurs when there is shortening of the lids due to scarring of the conjunctiva. Ask the patient to gently close their eyes as if they're sleeping and look with the torch to see if there is a gap between the lids. Blood pressure and pulse. Measure the blood pressure and the pulse to check for an abnormally high blood pressure or an irregular pulse. It is very important that you record the history and the clinical findings in the patient's notes or a logbook. You should ensure that sufficient contact information is recorded so that the patient can be followed up. Consent practices vary between countries, and you should familiarize yourself with your national guidelines. If the patient has trichiasis that requires surgery, explain to them the nature of their problem, and that if left untreated, it may damage their eye and cause loss of vision. You should then explain to them that you think that they would benefit from surgery, as this will reduce their risk of blindness from trachoma. Briefly explain what the operation involves, and that they need to lie flat and still throughout the procedure, which will take about 20 minutes. You must tell them that after the operation they will have a firm pad on the eye until the next day. Therefore, if both eyes are operated on, they will not be able to see until these are taken off. Tell the patient about the potential complications of the surgery. Bleeding and bruising. Infection, which may need extra antibiotics. Over or under correction of the entropion, which might require a second operation. Recurrence of the trichiasis any time after the operation in around 10 to 20% of cases. Always remember to give the patient an opportunity to ask questions. Finally, depending on local practices, you should ask the patient to confirm their decision on a written consent form, either with a signature or a fingerprint. Before the operation, you should mark the eye that will be operated on with an arrow or with tape, or if both eyes are to be operated, then mark above both. Trachomatous trichiasis includes a wide range of clinical appearances and severity. At the most severe end of the disease spectrum, you might find the entire eyelid turned in, with all of the lashes touching the surface of the eye. In other cases, you might find some entropion, but with few or no lashes touching the eye. Some eyelids may have trichiasis, but with little or no entropion. These lashes may be either metaplastic or misdirected. Some eyelids may have only one or very few lashes touching the eye. These may be peripheral and never come into contact with the cornea. Given this range of disease severity, clinical management will vary significantly depending on the available resources and the level of training of the person doing the surgery. In addition, different countries have slightly different policies about who should be offered surgery and what procedure should be adopted. Therefore, you should familiarize yourself with your own country's national eye care program policy on the type of trichiasis surgery to do and indications for surgery. In this training DVD, we're going to describe in detail the two procedures which are in common use in trachoma control programs in endemic countries. These are the Bilamellar tarsal rotation and the posterior lamellar tarsal rotation procedures. In general, you should offer surgery to patients with trichiasis. If there is likely to be a big delay between when the patient is first identified as needing surgery and the date when the surgery can be provided, then the patient should be offered epilation. Similarly, if the patient refuses to have surgery, you should offer epilation and train them how to do this on an ongoing basis. There are some situations where it is not advisable to operate, even if the patient has trachomatous trichiasis. Surgeon factors. You should not operate if you're feeling nervous about operating, or feel your training has not been adequate, or you're concerned about your vision, or are under the influence of alcohol or drugs. Patient factors. You should not operate if the patient requires redo surgery, and you are not trained in this, as repeat surgery is technically more challenging. You should not operate if the patient has significant psychiatric problems, dementia, or a severe tremor, all of which can make surgery unsafe. Such patients should be referred to the regional hospital for management. Environmental factors. You should not operate if you do not have the correct equipment or the lighting is not adequate for surgery. Children. Sometimes trachomatous trichiasis can develop in children as young as 9 or 10 years old. These children are at high risk of developing visual loss. The management of these children is very challenging. You should refer children with trichiasis to a surgeon with a high level of training and previous experience of operating on children. You do not need a special operating room. You can perform the surgery in places like a school classroom or a village hall. However, you must ensure the room has been cleaned thoroughly before surgery and that it is large enough for the surgeon and an assistant to move freely. Focused artificial lighting is ideal but may not be available. You can perform surgery near to a window if the natural light is bright enough. Lay a sterile cloth on a table. This will be the sterile field. You must be wearing sterile gloves to do this. You should carefully remove other required items from the sterile drums and lay them neatly on the sterile table. The stool and operating bed should be in a position where good natural light is available. You should use a rubbish container for all clinical waste materials except surgical sharps. This rubbish should be incinerated after use. You must use a sharps bin for disposing of all sharps, such as needles and blades. It's important that this is conveniently located for the surgeon. The surgeon's sterile trolley should be placed at the side of the operating bed. The surgical equipment kit for trichiasis surgery usually contains the following items: a scalpel holder and scalpel blade, a needle holder such as the Silcox needle holder or Barraquet's needle holder, toothed forceps, non-toothed forceps, dissecting scissors, artery forceps, a traboo plate. Sterilization is the elimination of infectious agents including bacteria, fungi and viruses. We strongly recommend that this is done with steam, under pressure in an autoclave, or dry heat in a sterilizing oven. Chemical processes and boiling do not usually destroy spores and are not recommended. In this chapter we will describe the use of the steam autoclave. This specific model of autoclave is widely available in trachoma endemic regions. If you use a different model of autoclave, you must read and carefully follow its instructions. You should use the autoclave in a clear area. Place the items to be sterilized on a clean table or shelf nearby. Pour water into the autoclave up to the level of the top of the tripod stand inside. Load the drum with the items to be sterilized. You must check the drum to ensure that the vents are open. Close the drum lid and lock the vent collar in the open position. Place the drum in the autoclave and close the autoclave lid by rotating it clockwise until it locks into position. You must ensure the autoclave lid is correctly closed. If this is not done properly, the autoclave is extremely dangerous when being heated. Check both taps are closed and place the autoclave on a kerosene burner. Some autoclaves are designed to be heated using an electrical supply. After several minutes, the steam produced causes the pressure to rise in the autoclave. You can see this on the pressure gauge. When the pressure reaches 15 plus or minus 1 psi, steam will come out of the pressure valve. You must record the time at which this happens. Continue heating for a further 20 to 25 minutes, then turn off the heat source. Then open the lower tap, which is the vacuum release tap. All the steam and water will then drain from the autoclave. As soon as the water stops draining, close the tap again and leave the autoclave for 5 to 10 minutes. A further vacuum develops in the autoclave, which will now dry the sterile contents. Then open the upper tap, which is the steam release tap, allowing all remaining steam to come out. The pressure gauge should now drop to 0 psi. Only open the autoclave when the pressure is 0. Then remove the drum and immediately close the vents. There are some crucial safety points that you must always follow when using an autoclave. You must carefully read and understand the manufacturer's instructions. When using the autoclave, you must follow the instructions carefully and exactly. You should be well trained in autoclave usage and intermittently supervised. There is a danger of transmitting HIV, hepatitis viruses or other infectious diseases if the surgical materials are not properly sterilized. And there is also a danger of causing serious injury if the autoclave is not used correctly.